Good day everyone. We, TUL-ID Jane Casey, Tumulak Monique, VERANCES JC Moore, and VILVESTRE JUVILYN are the Group 11, and today we are going to present our case study. Next slide please. Here are the flow of our presentation, which consists of introduction, patient characteristics, or the signs and symptoms, laboratory findings and discussion of the test involved, clinical hypothesis and impression, pathophysiology of the possible disease involved, further lab testing, and answers and discussion. Next slide please. The case that we are going to present is about a farmer who worked for 10 years in the farm. So, next slide please. What is pulmonary fibrosis? Pulmonary fibrosis, also known as farmer's lungs, is a type of extrinsic allergic alveolitis, or EAA, is an inflammatory respiratory disease with immunologic mechanisms that damage the terminal airways. This occurs when the person is exposed too long to biological dust, given the fact that he works at a farm where decayed compost, hay, and stored damp crops are located. And this happened due to the species called actinomyces, which is common at temperature between 40 to 60 degrees Celsius and humid places because their species developed within the state. And factors that may affect or worsen the condition is the intensity, frequency, and duration of the exposure. These three factors can really make the condition worse because all of it are considered to making the species or disease thrive within our system, and could also induce hypoxia and lower lung compliance if the acute exposure is severe. If the exposure is prolonged and persistent, the lung parenchyma is disrupted and collagen is deposited, which leads to decreased lung volume. And pulmonary fibrosis is the most common type of extrinsic allergic alveolitis that records high incidence of the disease, with an incidence recorded about 8 to 540 cases per 100,000 person affected per year, and has a percentage of 0.4 to 7% of the farmers affected to the disease.
Patient characteristics, signs and symptoms. As mentioned earlier, the patient had developed visible symptoms such as weight loss, cough with blood, shortness of breath, and flu. The cough related to pulmonary fibrosis is dry and persistent, which does not seem to go away. As the scarring increases, the patient's lungs are less able to expand to allow the patient to take deep breaths, and the level of oxygen in the patient's blood can start to drop, which explains why the patient experiences feeling breathless. The blood in the patient's cough can be associated with triggering factors such as smoking or secondhand smoking. Thereof, as the patient regularly works with his brother on the farm who smokes up to 60 cigarettes a day. It can also be from the inflamed lungs caused by extrinsic allergic alveolitis, also known as hypersensitivity pneumonitis, a non-atopic, non-asthmatic allergic lung disease. Weight loss is also one of a series of reported symptoms in pulmonary fibrosis. According to a range of health resources, weight loss in pulmonary fibrosis is described as being gradual, unintended, and inexplicable in patients with the disease. People with pulmonary fibrosis tend to lose weight slowly over time as the disease progresses. For the history of the patient, he had no past experiences with heart problems, so the chance that the patient is suffering from cardiovascular disease is reduced. This is important because patients with pulmonary fibrosis have to wait a long time to be diagnosed, and sometimes they are given an incorrect diagnosis such as heart diseases, because most frequently, some types of heart diseases have similar symptoms, and both diseases most commonly affect men aged over 60 years, or those who smoke or affected by secondhand smoking. As such, some patients have both pulmonary fibrosis and heart disease, which should be noted as different heart diseases can affect the choice of medicines or prescribed for pulmonary fibrosis. There was also no history of other lung diseases, so the shortness of breath can be attributed to the fibrosis itself.
So the previous table are the tests and results of the following tests that Mr. Frank undergo. These are the precipitin test, intradermal injection of M-finite, bronchoalveolar lavage procedure, lung biopsy, and immunofluorescent analysis of bronchial biopsy. The first test is test for precipitating antibodies, or the precipitin test. This identifies the presence of proteins that are found only in human blood. The test result is positive. which means it detects the presence of a specific antigen, indicating that there is a presence of relatively large amounts of antibody and is correlated with clinical evidence of hypersensitivity pneumonitis. The serum precipitating antibodies testing is based on suspected exposure, which is useful in differentiating extrinsic allergic alveolitis or the hypersensitivity pneumonitis from other fibrosing interstitial lung diseases. In a study about the utility of precipitating antibody testing in the diagnostic evaluation of chronic hypersensitivity pneumonia, precipitants were reported up to 30% of farmers and up to 50% of pigeon breeders in absence of clinical disease. Hence, positive findings help suggest and document patient exposure even before the onset of the symptoms. However, the falsely negative results may be due to the disappearance of serum antibodies approximately after 2 to 3 years from the cessation of exposure and to gradually decrease in serum titer after repeated exposure to high levels of antigen. During the intradermal injection of M-Fini, there is an Artus reaction. So it refers to an acute localized inflammation response that typically occurs after vaccination. The classic Artus reaction involves repeated injection of a foreign antigen into the skin of an experimental animal until circulating antibodies to the antigen develop and react with the antigens at the site of injection to produce immune complex mediated acute inflammation. So the third one is the bronchoalveolar lavage or BAL. This is a minimally invasive procedure that involves installation of sterile normal saline into a subsegment of the lung, followed by suction and collection of the installation for analysis. The result of BAL procedure shows an increased number of T lymphocytes and mast cells. CD8 plus cells predominate with increased expression of MHC class II antigens and activation markers. With the result of the BAL procedure, patients with extrinsic allergic alveolitis or the EEA and sarcoidosis characteristically have an increased percentage of lymphocytes in their BAL. It is well accepted that patients with EEA have a large number of lymphocytes in their BAL. It has been previously described that an abnormal increase in the number of lymphocytes are also often seen in symptomatic dairy farmers and in subjects with previous farmer's lung disease or the FLD. For the lung biopsy, the result shows a granulomatous infiltrates of mononuclear cells and thickening of alveolar walls with lymphocytic and plasma cell involvement. Although surgical lung biopsy is not necessary when a confident diagnosis can be made based on exposure, history, and HRCT features, it can be useful in distinguishing the stage of hypersensitivity pneumonitis. In its early stages, a nonspecific type of interstitial pneumonia is usually patchy and distributed around bronchioles with areas of intervening uninvolved parenchyma. In the later stages, the process becomes more diffuse. As in the case of the patient, the alveolar walls exhibit infiltration by lymphocytes, plasma cells, multinucleated giant cells, and only occasional eosinophils and neutrophils. This indicates that the patient is suffering from the chronic form due to prolonged exposure to small amounts of antigen, primarily mold spores. So for the last test involved is the immunofluorescent analysis of bronchial biopsy. The result is there is an evidence of actinomycetes antigen in the alveolar spaces. Evidence for actinomycetes antigen in the alveolar spaces was observed during the immunofluorescent analysis of bronchial biopsy. This is caused by the humidity and heat in the farm that might have sparked the growth of microorganisms. Also, the dust formed from the handling of such material contains a vast number of protein particles that enter the respiratory tract and instigate diffuse alveolitis. These antigens are the thermophilic actinomycetes, such as the M. fini, M. polyspora, T. candidus, and T. vulgaris, as well as others. Initially, the patients may present with very nonspecific symptoms of mild fever, weight loss, shortness of breath, and chest pain, in which the following are some symptoms that Mr. Frank shows. Overall, analyzing the lab results, the data reveals that the diagnosis is the extrinsic allergic alveolitis, or the EEA, also known as the farmer's lung, as indicated by all test results. To further discuss the case, next is the clinical hypothesis or impression.
Clinical hypothesis and impression. The diagnosis of Mr. Franks is pulmonary fibrosis with farmer's lung disease. It is considered as hypersensitivity pneumonitis, or HP, or extrinsic allergic alveolitis. This because the patient had inhaled thermophilic actinomycete that were growing on his stored damp crops and commonly grow substantially in the spring season when hay was utilized.
So just for a quick run through, in our case, a diagnosis of pulmonary fibrosis was made with extrinsic allergic alveolitis as the underlying cause. So for the pathophysiology of the patient's condition, the onset was due to hypersensitivity or allergic reactions to organic antigens. So in the case presented, this occurred during the exposure of the patient to moldy hay, which is very common, especially as the patient was working in a farm. So the immune responses with extrinsic allergic alveolitis antigens involve both adaptive and innate immunity. So looking back from the beginning, during the very first exposure to antigens, the symptoms occurred and the immune system became sensitized. However, subsequently during the second exposure, as we can see on the picture, instead of producing a normal response, the expressed normal T cell and RANTES, which is a chemotactic factor, attracted neutrophils to the alveoli and produced immune complexes. So it is in people with repeated exposure that extrinsic allergic alveolitis is triggered by T lymphocytes via a Th1 immune response, which is responsible for both lymphocyte alveolitis and granuloma formation. So here, humoral, cellular, and cytokine immune responses all cause the progressive inflammation, resulting in a granulomatous formation in the lung parenchyma. So, granulomatous inflammation, it requires the expression of Th1 cytokines, including tumor necrosing factor alpha, interleukin 12, and interferon gamma. So, it is this continuous exposure to antigens that activated neutrophils and fibroblasts, which resulted in collagen deposition and therefore fibrosis. So in the next picture, finally, we can now proceed to pulmonary fibrosis. So again, it is developed as a result of the repeated subclinical injury leading to epithelial damage and subsequent destruction of the alveolar capillary basement membrane. Right, so next slide please. Yeah, so this will activate the cells in the alveoli to release pro-inflammatory cytokines and chemokines. So these mediators will activate resident fibrocytes and recruit more circulating fibrocytes. So we can see the fibroblast activation on this very picture, right? Next slide please. Yeah, so on top of this, pro-fibrotic chemicals such as platelet-derived growth factor or PDGF and transforming growth factor beta are secreted by alveolar cells, which stimulate fibroblasts to activate, proliferate, and then differentiate into myofibroblasts and stimulate collagen synthesis. Next slide. Right, so following that, the fibroblast and myofibroblasts will organize into fibrotic foci. So there is already fibrotic foci here. Next slide, please. Okay, so growth factors targeting tyrosine kinase pathways are released continuously, which will promote fibrotic foci formation and evolution into a fibrosed lung. Right, so it is important to note that on the next slide, that fibroblast proliferation and collagen deposition is a normal repair mechanism with acute injury to the lungs. However, it is the repeated insults that lead to a profibrotic event where there is an abnormal repair process characterized by an abnormal re-epithelialization, abundance of myofibroblasts, and the formation of a collagen matrix. So in the last picture, yeah, next slide. Here we can observe that there is already a poor gas exchange. So the process proceeds to excessive matrix formation, leading to the destruction of the normal lung architecture and loss of function. So this will result in loss of capillary surface areas and gas exchange units. So this actually explains why the diffusing capacity of the lung for carbon monoxide, or DLCU, of the patient was greatly reduced.
Now, for the further lab testing. At present time, there are no generally accepted or validated staging systems to identify the severity of pulmonary fibrosis. Nevertheless, a high-resolution computerized tomography, or what you call a CT scan, can be particularly helpful in determining the extent of lung damage caused by pulmonary fibrosis. CT scanners can help point out clinical thresholds for initiating treatment and sensitively distinguish early progressive from chronic stable disease that can help physicians modify therapeutic decisions. Since the diagnosis of pulmonary fibrosis requires exclusion of other known causes of intestinal lung diseases, serological testing can also be done to exclude connective tissue diseases as a potential cause of the intestinal lung disease. Last is the answers and discussion. So here is the results of investigations. A diagnosis of extrinsic allergic alveolitis EEA was made. In this case, Mr. Franks had inhaled thermophilic actinomycetes that were growing on his stored damp crops. This was especially prevalent in the spring when the hay was put out the herd. This disease variant is therefore known as farmer's lung. Management consisted primarily of allergen avoidance using an industrial breathing mask. This patient needed oral corticosteroids to reduce the parenchymal inflammation in the lungs. Questions are the following. Number 1. Are precipitating antibodies characteristics of extrinsic allergic alveolitis, or the EEA? So EEA is characterized by interstitial and alveolar inflammation. The presence of precipitating antibodies against the offending antigens along with clinical symptoms and signs developed in an appropriate environment, consistent chest radiograph or high-resolution computed tomography, or the HRCT, bronchoalveolar lavage or BAL, lymphocytosis, decreased carbon monoxide diffusion capacity, and granulomatous reaction on lung biopsies, and a positive inhalation challenge are seen as some of the diagnostic indicators of farmer's lung disease, or the FLD, and bird breeder's lung, or the BBL, the most common form of extrinsic allergic alveolitis. Also, according to Otani Y et al. 2003, the presence of immunoglobulin G precipitating antibodies in the serum of affected patient is regarded as evidence of inhalational exposure to these antigens. So these antibodies indicate exposure to and the potential to respond to subsequent antigen inhalation. Upon exposure, macrophages, plasma cells, and T lymphocytes infiltrate into the lungs. There is persistence of inflammation until exposure to the antigen is stopped. Symptoms include recurrent of fevers, myalgia, chills, cough, and breathlessness. Moreover, in the study of Lacasse et al., it has been identified serum precipitants as a significant predictor of HP, regardless of exposure. We have odds ratio 5.3 or 95% confidence interval CI of 2.7 to 10.4. However, the choice of antigens tested and the use and interpretation of tests were left to each investigating center according to their local practice. Thus, the diagnostic value of precipitants could not be assessed reliably.
So what is the mechanism of lung damage? So there are stages that must be followed if it leads to development of a permanent fibrotic scar due to excess accumulation of extracellular matrix, or the ECM. So first is clotting and coagulation. After tissue damage, epithelial cells or the endothelial cells release inflammatory mediators that initiate an antifibrinolytic coagulation cascade that triggers clotting and development of a provisional ECM. Next is inflammatory cell migration. Migration phase activated macrophages and neutrophils debride the wound and eliminate in it invading organisms. Third is the fibroblast proliferation and activation. Myofibroblasts are recruited from a variety of sources, including local mesenchymal cells, bone marrow progenitors called fibrocytes, and via a process called epithelial mesenchymal transition, or the EMT, wherein epithelial cells differentiate into fibroblast-like cells. And lastly, tissue remodeling and resolution. Myofibroblasts promote wound contraction, a process where the edges of the wound migrate toward the center and epithelia or endothelial cells divide and migrate over the temporary matrix to regenerate the damaged tissue.
Number 3, is pulmonary fibrosis likely to continue when the patient is removed from exposure to the antigen? So actually, some types of pulmonary fibrosis are reversible, while others are not. So most reversible fibrotic lung diseases are those that are secondary to lung injury caused by infection or drug toxicity. So once the hazard is eliminated, lung fibrosis gradually resolves with treatment. On the contrary, the lung scarring that occurs in some pulmonary fibrosis, like in the case of idiopathic pulmonary fibrosis, cannot be reversed anymore. So, there is no current treatment that has proved effective in stopping the progression of the disease. This is due to the persistent activation of myofibroblasts, leading to excessive scar hyperplasia and organ fibrosis. So, there is already an altered level of apoptosis resistance in idiopathic pulmonary fibrosis myofibroblast that results in their sustained activation and persistent pulmonary fibrosis. So it really cannot be reversed anymore. Yeah, so for the next slide, I am showing a picture of lung transplantation because it can actually be an option for people with pulmonary fibrosis. However, a lung transplant can involve complications such as rejection and infection and may only improve symptoms temporarily or slow the disease progression. So it can only function at that extent.
Question number 4. Does cigarette smoking have an effect on the course of the disease? The answer is yes. Next slide, please. Exposure to damaging agents such as cigarette smoke influences the development of the pulmonary fibrosis as well as the heterogeneous behavior. In the study of Otsuka et al., the obtained results suggest that smoking may make farmer's lung disease insidious and chronic, as well as deteriorates the clinical outcome. Cigarette smoking contributes to the pathogenesis of pulmonary fibrosis. Although this may depend on differences in exposure levels on people, it can increase in people who smoke because it can reduce IgG responses to inhaled antigen, affect cytokine production, and alter the functions of macrophages. Cigarette smoke contains particulate matter as well as numerous chemicals including highly toxic reactive oxygen and nitrogen species. This has been said to alter both the oxidant or antioxidant balance, the protease or anti-protease balance on the lungs, as well as promoting cellular apoptosis and necrosis in the epithelium and generating DNA and lipid intermediates. Cigarette smoke also alters the way in which macrophages recognize foreign particles and pathogens. The debris that is generated from apoptotic and necrotic cells has recently been shown to enhance inflammation and downstream remodeling through various receptors including TUL-like receptors and other pattern recognition receptors, which mimics alveolar macrophages. Due to the multitude of mediators capable of activating cells, the combination of mediators may have a synergistic effect in the lungs of patients with pulmonary fibrosis and their chance of survival. According to studies, non-smoker patients and current smokers have longer survival time than ex-smokers. This is because smokers are prone to develop the interstitial lung abnormalities, which usually progresses as they continue smoking. On top of that, smoking can indirectly affect the survival of patients with pulmonary fibrosis through the development of bronchogenic carcinoma. Conceivably, this significantly affects the course of the disease, as the patients are reported to exhibit worse prognosis compared to pulmonary fibrosis without lung cancer, or conversely, lung cancer without pulmonary fibrosis. And that ends the discussion of our case study. Thank you so much for listening.